So if a patient using a copper IUD manages to conceive, there is a 1 in 16 chance that the resulting pregnancy is going to be a life-threatening emergency. And if they are using a hormonal IUD, I mean, that risk jumps to 1 in 2.
Yeah, it is honestly one of the most counterintuitive paradoxes in reproductive medicine. The very interventions designed to prevent pregnancy altogether drastically shift the ratio of complications if they, happen to fail.
Right, and when you are standing in a triage unit at 2 a.m. and you're staring at an ultrasound screen with a patient's life on the line, you don't have time to ponder the paradox.
No, definitely not. You need to know exactly what to do right in that exact second.
Exactly. When you first start studying medicine, you spend years buried in these massive, heavy textbooks. You read about the human body as if it's this perfectly engineered, predictable machine. But the reality of clinical practice is just a state of controlled chaos.
Absolutely. When adrenaline is pumping and multiple physiological systems are crashing at once, a 3,000-page theoretical textbook is completely useless. I mean, you don't need theory. You need an immediate, actionable protocol.
Which is why today's deep dive is centered on a resource born directly out of that 2 a.m. clinical chaos. We are looking at the Johns Hopkins Handbook of Obstetrics and Gynecology.
It's a classic.
It really is. We are extracting the highest yield clinical pearls for your medical toolkit today. And the origin story of this source is actually fascinating. Nearly 20 years ago, a group of senior residents realized they needed a way to standardize care and educate their junior residents on the fly.
Right.
So they created this practical spiral-bound survival guide.
And right in the preface, the authors include a really crucial disclaimer. They state that medicine is an ever-changing science. Because while we are going to dive into some very hard, fast rules and protocols today, clinical practice requires constant critical thinking.
You can't just operate on autopilot.
Exactly. You always have to update your underlying knowledge of human physiology.
Okay, let's unpack this. Because our mission today is to translate these dense medical protocols into memorable, practical knowledge that you can actually use. So to do that, we are going to trace the clinical timeline, starting at the high-stakes finish line, the delivery room.
Yeah, that is an environment where split-second decisions are entirely governed by strict, data-driven protocols.
So let's look at the timeline of pregnancy, specifically post-term management. The handbook draws a very firm line in the sand here. Once a patient hits 41 weeks and 0 days, fetal testing kicks into high gear with twice-weekly modified biophysical profiles, or BPPs.
Right, so let's break down the mechanics of what we're actually measuring there. A modified BPP combines a non-stress test with an ultrasound to measure the amniotic fluid index.
The AFI.
Exactly. Now, the non-stress test looks for accelerations in the baby's heart rate when it moves. If the heart accelerates, it basically proves the fetal autonomic nervous system is intact and well oxygenated.
And the amniotic fluid index, we're essentially measuring pockets of fluid around the baby. But why does that specific measurement become so critical right at that 41-week mark?
Well, it's because of how amniotic fluid is created at that stage. Late in pregnancy, amniotic fluid is predominantly fetal urine.
Oh, right.
Yeah. The placenta is essentially a temporary organ with an expiration date. Past 40 weeks, it actually begins to physically degrade. You see these microscopic infarctions and calcification.
So it's literally breaking down.
Yes.
Right.
And blood flow to the fetus becomes compromised. So when a fetus isn't getting enough oxygen, its brain automatically shunts blood away from the kidneys and pushes it toward the heart and brain to protect them.
So decreased blood to the kidneys means decreased urine output.
Right.
Which means the amniotic fluid levels drop. It's like a direct proxy for placental failure.
Exactly. The AFI isn't just about the baby having a cushion. It is a real-time indicator of whether the placenta is still doing its job.
That makes perfect physiological sense. Now, the absolute hard stop for this monitoring is 42 weeks and 0 days. At that point, the protocol dictates the induction of labor. But this brings up a massive controversy.
Oh, huge.
There is this incredibly common assumption, both in the public and even among some medical professionals, that inducing labor inherently increases the risk of ending up with a cesarean delivery.
Yeah, it is a pervasive myth. The assumption is that by, artificially forcing the body into labor, you trigger this cascade of interventions that inevitably leads to surgery.
Right.
But the clinical data explicitly debunks this. When induction of labor is compared to expectant management, which just means waiting for labor to start naturally, there is either no difference in the rate of cesarean deliveries or the data actually shows a decreased risk of a CD for women undergoing induction.
It's completely counterintuitive. I mean, why would interfering result in fewer surgeries?
Well, because if you wait for natural labor past a certain point, the baby just continues to grow larger, increasing the risk of getting physically stuck.
Okay, yeah.
And, like we said, the placenta continues to degrade, which increases the risk of fetal distress during contractions. Both of those scenarios lead directly to emergency C-sections.
So inducing earlier just avoids those two massive risk factors altogether.
Precisely.
That distinction between assumption and data is exactly why handbooks like this exist in the first place. But speaking of the delivery room, the protocols also cover catastrophic obstetric emergencies. And the one that requires the most immediate mechanical intervention is uterine inversion.
Oh, yeah. It is one of the most severe emergencies an obstetrician will ever face. It results in instantaneous, massive hemorrhage.
The clinical presentation in the book is broken down into 4 degrees of severity. First degree, the fundus, the top of the uterus inverts but remains inside the uterine cavity. Second degree, it protrudes through the cervix.
Right.
Third degree, it protrudes beyond the vaginal opening. And fourth degree, the uterus and vagina are completely inverted outside the body. It sounds exactly like pulling a sock inside out.
It really does.
But clinically, how does an organ that is so muscular, so thick and structurally sound just collapse in on itself so dramatically?
It all comes down to the unique physiological state of the postpartum uterus.
Wow.
During pregnancy, the myometrium, that's the uterine muscle, expands massively.
Yeah.
But once the baby is delivered, that muscle is supposed to contract down very tightly.
Okay.
That contraction physically shears the placenta off the uterine wall, and it acts like a biological tourniquet, just clamping down on all those bleeding blood vessels.
Right. So the uterus essentially acts as its own internal pressure bandage.
Yes, but if that uterine muscle remains relaxed and floppy, a condition called uterine atony, it loses all of its structural integrity. So if there is downward traction on the umbilical cord before the placenta has detached, or maybe sudden aggressive pressure on the top of the abdomen, that uncontracted muscle just caves inward.
Wow.
It literally turns inside out and it drags its own engorged blood supply right with it.
Which means the biological tourniquet fails entirely. You can definitely see why a resident needs a strict, step-by-step reversal protocol when staring at that.
Absolutely.
And we see that same reliance on rigid protocols with preeclampsia. For preeclampsia with severe features, the monitoring parameters are mathematically precise. Maternal vitals and symptoms are checked every 8 hours, daily non-stress tests, twice weekly BPPs.
That rigid code, every 8 hours protocol really highlights the cognitive safety net these handbooks provide. Preeclampsia is a systemic vascular disease. The blood vessels are spasming all over the patient's body.
This was highly unpredictable.
Very. They can seize or stroke out with very little clinical warning. By imposing this strict order onto a state of physiological chaos, doctors don't have to rely on their memory or gut instinct. You just execute the checklist.
It removes the cognitive load when you need your brain to be focused entirely on execution.
Exactly.
Now, if we follow the timeline backward, let's look at what happens when pregnancy goes dangerously wrong at the very beginning. Ectopic pregnancies.
Right. An ectopic pregnancy occurs when the fertilized egg implants outside the main cavity of the uterus. Statistically, this accounts for about 6% of all pregnancy-related maternal deaths, mostly due to internal bleeding when the structure ruptures.
The recurrence risks are what really stand out to me here. If a patient has one ectopic pregnancy, the risk that having another one jumps to 8 to 15%. But if they've had 2 or more, the risk of recurrence is over 25%.
Yeah, more than 1 in 4.
That's staggering.
It is, and this brings us to the underlying mechanism of transport. The fallopian tube isn't just some hollow passive pipe. It is a biological conveyor belt lined with these microscopic hair-like structures called cilia.
And their job is to sweep the embryo along.
Exactly. These cilia sweep the fertilized embryo down into the uterus.
So if a patient has a pelvic infection or maybe a previous ectopic that required surgery,
those cilia get permanently damaged or paralyzed, and scar tissue forms. So the embryo gets stuck on the conveyor belt and eventually just implants right into the wall of the tube. And the structural damage remains, which is exactly why the recurrence risk is so astronomically high.
that scarring mechanism also perfectly explains a highly dangerous variant called the interstitial or corneal ectopic. This is when the embryo implants in the tiny segment of the fallopian tube that actually traverses the muscular wall of the uterus itself.
Yeah, this requires a clear mental map of the anatomy. A standard tubal ectopic pregnancy causes severe pain relatively early. The fallopian tube is narrow and rigid, so as the embryo grows, the tube stretches, and the patient feels that pain and comes to the emergency room.
But the interstitial segment is buried inside the thick, expanding myometrium of the uterine wall.
Exactly. Because it's surrounded by thick muscle designed to stretch, it dilates completely painlessly. The muscular wall masks the early symptoms, which delays clinical presentation.
So the pregnancy just grows much larger before anyone realizes it's there.
Right. And when it finally does rupture, it isn't just a small tube bursting. It is literally tearing open the highly vascularized uterine muscle itself.
It's a literal ticking time bomb hidden by the body's own anatomy. Which actually brings us back to that massive clinical pearl we mentioned at the start, the contraception paradox. We know that intrauterine devices and bilateral tubal ligations, getting your tubes tied, are incredibly effective at preventing pregnancy.
They are excellent at what they do. The overall rate of pregnancy is exceptionally low.
But if a pregnancy does occur, the statistics shift completely. As we noted, 1 out of 2 pregnancies in a Mirena user will be ectopic. For a Paragard copper IUD, it's 1 in 16. And similarly, 1/3 of pregnancies following a tubal ligation are ectopic, particularly if bipolar coagulation was used.
Let's clarify bipolar coagulation first. That is a specific surgical technique where electrical current is used to burn and seal the ends of the fallopian tubes. It creates a very stark physical block.
So why do these highly effective methods create such a high proportion of life-threatening ectopics when they fail?
Well, it requires understanding what these methods actually stop. An IUD makes the uterine cavity highly inhospitable to an embryo. But it does not stop the ovary from releasing an egg, and it doesn't entirely stop a determined sperm from swimming past the IUD and into the fallopian tube.
Wait, so fertilization still happens out in the tube?
Yes. The embryo travels down, hits the uterine cavity, realizes it can't survive there because of the IUD, and in some cases, it implants backward into the tube.
Oh, wow.
Yeah. And with a tubal ligation, if the electrical burn leaves a microscopic fistula, like a tiny tunnel sperm, which are microscopic, can actually swim through it. But the resulting embryo, which is much larger, gets trapped behind the scar tissue and implants in the tube.
I see. So the overall number of ectopics is low because the pregnancy rate is low, but the ratio of danger skyrockets. That distinction between overall rate and proportional risk is so vital for anyone taking a clinical history.
Absolutely.
Now, before we leave early pregnancy, we really must touch on post-abortion follow-up. This applies to both spontaneous miscarriages and induced abortions. The protocol is clear. Fertility returns immediately.
It does. The clinical data shows ovulation can occur within just 2 weeks of the pregnancy ending.
But here's the diagnostic trap. The pregnancy hormone, HCG, takes an average of 31 to 38 days to clear from the blood and become non-detectable.
Meaning a patient could technically ovulate at day 14, conceive a brand new pregnancy, and present to the clinic testing positive.
Right.
If a clinician assumes that positive test is just leftover HCG from the previous event, they completely miss a new, potentially ectopic pregnancy. It underlines exactly why immediate contraceptive counseling is a mandatory part of post-abortion care.
That biological overlap is a perfect example of why linear flowcharts just fail in real life. All right, let's follow that common thread of tubal scarring and transition into the diagnostic realms of gynecology and reproductive endocrinology. We're looking at the non-pregnant pelvis now, starting with evaluating infertility.
It is a profoundly frustrating diagnosis for patients, especially because in 25% of couples, the infertility is totally unexplained.
But for the ones we can explain, we look systematically at the anatomy. Uterine factors account for 2 to 3% of cases. These are usually structural filling defects. If the uterus is a room, these are things taking up space so the embryo can't unpack. Submucosal fibroids, or synechiae.
Right. Synechiae are essentially dense webs of scar tissue that glue the front and back walls of the uterus together. They usually form following a severe infection or a previous surgery. An embryo simply cannot implant into a web of vascular scar tissue.
And then there are congenital Müllerian anomalies, which affect up to 10% of women and are found in 3% of women with recurrent pregnancy loss.
This takes us all the way back to early embryonic development. In a female fetus, the reproductive tract forms from 2 separate tubes called the paramesonephric, or Müllerian ducts. These 2 tubes are supposed to merge together in the midline, kind of zipping up from the bottom to the top, to create a single hollow uterus and the upper vagina.
But if that biological zipper gets stuck or the wall between them doesn't dissolve,
You end up with severe structural anomalies. The most common one causing miscarriage is a septate uterus, where a wall of tissue divides the uterine cavity right in half.
And why exactly does that cause recurrent miscarriages? Is it just a lack of physical space?
It's actually a lack of blood. That dividing wall, the septum, is made of fibrous avascular connective tissue. It doesn't have the rich blood supply of normal uterine muscle.
Ah.
So the embryo happens to implant on that fibrous wall. It starves of oxygen and nutrients, resulting in an early pregnancy loss.
It's a structural failure leading to a nutritional failure. Now, moving from structural issues to oncology, the handbook gets deep into how we diagnose ovarian masses. It describes how specific tumors, specifically germ cell and sex cord stromal tumors, secrete markers like LDH, AFP, HCG, estradiol, inhibin, and testosterone. These act as chemical fingerprints in the blood.
The underlying biology here is fascinating. Take germ cells, for example. These are the totipotent cells in the ovary that are destined to become eggs. They possess the complete genetic constructions to build an entire human being.
Right, so when they mutate and turn into a tumor...
They get confused. They basically try to build an embryo on their own.
Oh, wow.
Yeah, that is exactly why a young patient with a germ cell ovarian tumor will suddenly have sky-high levels of HCG, the pregnancy hormone, or alpha-fetoprotein, AFP, which is a protein normally only produced by a fetal liver. The tumor is mimicking fetal development.
So by drawing those specific labs, you can essentially tell what specific type of rogue cells the tumor is made of before you ever make a surgical incision.
Which completely dictates whether the surgeon takes a conservative approach to preserve fertility or an aggressive oncological approach.
That's incredible. While we're in the oncology section, there is a specific condition the handbook details called pseudomyxoma peritone, or PMP. It's an oncological condition where tumors continuously secrete massive amounts of mucinous, gelatinous material until it fills the entire abdominal cavity. But what really surprised me is that this prestigious Hopkins handbook informally refers to it as jelly belly.
It stands out, doesn't it?
It really does. I mean, I have to ask, do informal, slightly cartoonish terms like jelly belly actually belong in serious medical education? Doesn't it undermine the rigor of the science?
That is a very valid critique, but it ignores how the human brain actually processes information under extreme stress. In high-pressure medical environments, visceral, highly visual mnemonics are scientifically proven to aid rapid cognitive recall.
So you're saying it basically operates as a cognitive hack?
Exactly. When a surgical resident opens an abdomen in the middle of the night and sees liters of this thick mucinous fluid, the phrase jelly belly immediately connects to the complex diagnosis of PMP in their brain.
It bypasses the big words.
Right, it completely bypasses the need to search through dense, multisyllabic academic terminology. By making rare conditions instantly recognizable, that informal language actually enhances clinical safety.
You need the information accessible in milliseconds, not minutes. Okay, as we move through the clinical timeline of a patient's life, we arrive at the final phase covered in the handbook, menopause and advanced urogynecology. Let's establish the baseline here. Menopause is strictly defined as 12 consecutive months without menses.
Right, and the average age for this transition is 51, with a normal physiological range stretching anywhere from 43 to 57 years old. It marks the permanent end of ovarian estrogen production.
And as that estrogen drops, the entire anatomical landscape of the pelvic floor shifts and atrophies, which brings us to urogynecology. The handbook details interventions for overactive bladder symptoms. When these symptoms become intractable, meaning standard medications and physical therapy completely fail, the surgical solutions are frankly remarkable. Let's look at interstim, or sacral nerve root neuromodulation.
This is, for all intents and purposes, a pacemaker for the bladder. A surgeon implants a small battery device that sends continuous mild electrical pulses directly to the S3 and S4 sacral spinal nerves.
But wait, I understand how pacing a heart works. You're shocking the heart muscle into a rhythm. How does shocking a spinal nerve in the lower back stop a bladder from spasming?
It comes down to interrupting a faulty reflex loop. The S3 and S4 nerves carry the signals back and forth between the bladder and the brain. In overactive bladder, the bladder is constantly screaming to the brain, "I need to empty right now," even when it's mostly empty.
Okay, so it's a miscommunication.
Exactly. By applying a constant electrical pulse to those specific nerves, the interstim device basically creates static on the line. It interrupts that hyperactive miscommunication, calming the reflex arc down.
And the data shows it yields a massive 60 to 90% improvement in symptoms.
Which is life-changing for patients who, couldn't even leave their homes due to incontinence.
And if the pacemaker approach doesn't work, the next step in the protocol is intradetrusor Botox. They inject 15 to 30 milligrams of Botox directly into the bladder lining.
Specifically into the detrusor muscle, which is the smooth muscle wall of the bladder itself.
Now, we usually think of Botox strictly for cosmetic reasons, like paralyzing facial muscles to stop wrinkles. How exactly does injecting it into an internal organ work?
The biological mechanism is exactly the same. Botox blocks the release of a neurotransmitter called acetylcholine at the neuromuscular junction. Without acetylcholine, the muscle physically cannot contract.
So it forces it to relax.
Right. By injecting highly diluted amounts evenly across the detrusor muscle, medicine elegantly repurposes a paralyzing neurotoxin to partially paralyze a spastic bladder.
And it offers a 40 to 80% success rate lasting 6 to 12 months, literally giving patients back their functional independence.
It's amazing. And it really brings our entire conversation full circle back to the book's preface about medicine being an ever-changing science. Think about it. The original authors of gynecologic textbooks a few generations ago couldn't have fathomed using electrical nerve jammers and purified botulism toxin to cure bladder spasms.
No, it would have sounded like pure science fiction.
It really would have.
And that actually brings us to the end of our dive. To summarize, the Johns Hopkins Handbook of Obstetrics and Gynecology is a brilliant resource precisely because it bridges the massive gap between heavy theoretical physiology and the urgent practical reality of bedside patient care. It takes the why and turns it into an actionable how.
It is an absolute essential for anyone building their medical toolkit.
And since we know you, the listener, are actively building that clinical knowledge, we promised you a review scenario to reinforce the material today. So, put your clinical hat on. Here's your scenario. You are working in the emergency department, and you are treating a patient with acute abdominal pain. She recently conceived via IVF. You do an ultrasound, and it confirms a perfectly normal, healthy intrauterine pregnancy. Based on the mechanisms we discussed today, what specific rare diagnosis must you urgently rule out?
You must urgently rule out a heterotopic pregnancy. Even though you found a pregnancy safely inside the uterus, you have to scan the fallopian tubes.
Because the risk for a simultaneous ectopic pregnancy jumped from 1 in 3,900 to 1 in 100 the moment she used IVF.
Exactly. The mechanical force of flushing the embryos into the uterus during IVF can easily push one embryo backward into the tube while the other implants normally.
So do not let the intrauterine pregnancy give you false reassurance. Always look at the tubes. That is a clinical pearl that will absolutely save a life.
Definitely. And as we close today, I want to leave you with one final thought to mull over. If you look closely at the protocols in this handbook, a significant portion of them are actually dedicated to managing the complications of our own medical interventions.
That's true.
We talked about ectopics caused by IUDs and tubal ligations, the risks surrounding the induction of labor, and the heterotopic risks of IVF.
It's a fascinating paradox. We are constantly solving problems and inadvertently creating entirely new ones.
Exactly. So, as medical technology advances over the next 20 years and we invent even more complex, elegant interventions to solve today's problems,
Right.
what entirely new categories of complications will the next generation of residents have to write survival handbooks for?
Will the clinical chaos of the triage unit ever really be tamed or just replaced by a new set of murky waters? Until next time, keep questioning the protocols, keep learning the physiology behind them, and keep diving deep.